Good afternoon, everybody filtering in at the moment. So I'm going to give you a minute or two just to come in. But good afternoon, a very warm welcome back to Stewarts Soundbites. Thank you so much for joining us. Today we've got an absolute treat, and I've been looking forward to this ever since. Well, we've spoken before, Edmund, haven't we, on the telephone, and I've been looking forward to it since then. I mean, people joining this, Edmund, are going to know who you are, but just in case, I'm going to introduce you formally. So Edmund Bonikowski is a consultant in rehabilitation medicine, and you've been doing this work for a really long time. Edmund's, I think, 25 years, I read somewhere.
Yep.
So Edmund's also the founder of NRC Medical Experts, and we're going to put a link to that in the recording for you, so you can go and have a nosy at that. And Edmund's also the clinical director of Somerset Neurological Rehabilitation Centre. So you're a busy man, I think it's fair to say.
Sometimes.
So we had a bit of a chat on the telephone about what we were going to discuss today. We were a bit spoiled for choice, really, and I think that we kind of landed on this idea about how consultants in rehabilitation medicine kind of plays a part in multidisciplinary teams and kind of the role, and looking a little bit at lots of different issues. I'm not there's no point in me starting to talk about it now, but sure. I thought we'd just kick off. Edmund, first of all, thank you so much for being here, and I just wanted to kick off a wee bit, just for everyone's benefit, just to kind of, if you wouldn't mind, sort of summarizing the role of a consultant in rehab medicine as a good kind of starting point, isn't it, too?
Sure, yeah, absolutely. Well, first of all, thanks for having me, and I've been looking forward to this myself too. I'm going to speak relatively quickly because I know we've got pretty limited time. I mean, the role of the consultant in rehab medicine is essentially to look out for all of the medical aspects, so the disease-related aspects of a patient's condition, and to help optimize those, so that any therapy interventions from the OTs, the physios, the psychologists, and so forth, the nurses also, so that those interventions can be delivered to maximum benefit. Because as we all know, when we're unwell, we really can't function particularly well. And so that's our principal rationale, is to optimizing the medical condition of patients, both with respect to their initial injury or illness diagnosis, so whether they've had a traumatic brain injury, cord injury, or whether they outside of the injury sphere, whether they've got multiple sclerosis, for example. So getting the management for that primary condition as good as it can be medically, with medication and so forth, and making appropriate diagnoses of complications, and then also looking at intercurrent illness that may occur when somebody is, in a steady state. So whether they get pressure sores, or whether they get an infection of the urine or the chest, or whether they develop a depressive illness. So it's about being alert medically to physical, emotional, and psychological unwellness, I think, is probably the best way to put it. So we are very much generalists, the sort of modern generalist doctors. And I like to think, and I like to say, that there are no holds barred with us. There are no-go areas, because if you have no-go areas, then those are the weakness in which somebody deteriorates, and then their function can't be optimized.
Yeah, and I wanted to touch upon kind of introducing. So obviously I live in the world of litigation, so we get a case manager and an MDT set up, but normally in these kind of catastrophic cases. And I'm wondering, in your view, kind of the optimum stage at which to include input from a consultant in rehab medicine. And also, just picking up on something you said, I find really interesting, is how you see that role developing. And because you've mentioned, Edmund, it not necessarily just be in those early stages, those acute stages, but actually something that's ongoing. How does that play out in practice?
Well, I think importantly, we should be involved as early as possible in the clinical journey of anybody who's sustained a serious injury, a serious neurological injury in particular, in my discipline. And of course, that is supported by the concept of the rehabilitation prescription, emanating from the major trauma centres. And indeed, I had the privilege of being involved in the rolling out of that in Cambridge a decade or so ago. A fascinating experience to be a rehabilitation physician brought in, I mean, literally 12 and 24 hours after people were picked up off the road. To sit alongside the treating neurosurgeons, orthopedic surgeons, the intensive care people, and to bring rehabilitation up to an equivalence with those other disciplines was a very powerful experience. So I think the the basis for involving us early is well established in the health service, and the benefits to that to the patients is clearly understood, that we're able to articulate what the rehabilitation journey will probably look like, and to continue to update that as patients move out of the ITU into the inpatient neuro rehab unit, then potentially out into the community. So as early, I think, talking to the solicitors here and the case managers, as early as you can reasonably access a rehab physician, get them involved, get them to look at the patient, get them to look at the records, get them to formulate a rehabilitation prescription, or indeed look for a rehabilitation prescription in the patient's records. And sadly, I suspect that will be a very rare find, because it's something, because of resources, that has not found great traction, but it is still widely recognized as a really valuable document, particularly at the points of transition. So we should be involved, like any other clinician, at the front end, at the earliest opportunity, and then throughout the patient's journey, not necessarily sitting on, the MDT all the time. If a patient's condition is really stable medically, so they're not ill, then you can run MDTs perfectly satisfactorily without medical input. But I think some vigilance about when patients' conditions are changing, is there a medical cause for that? Involving the consultant in rehab medicine at that point, really powerful. And I think that there's quite an interesting analogy here, which Emma and I talked about before the discussion, and it's attributable to my colleague Julian Harris, who says, most of the time you don't need doctors. And he gives the analogy of being in an airplane. He said, I'm fine when I'm flying along straight and level in an airplane, no problem at all. I don't mind who's flying it. But when I'm taking off or when I'm landing, actually, I really want somebody who understands how to fly an airplane doing that, just in case. And the analogy is not complete, but actually I think there is a reassurance for patients and for other clinicians, particularly therapists and nurses, in having a medical contribution to the MDT. Essentially as a catch-all to say, well, are we missing a trick here? Is there a trick we're missing? And each profession has their own distinct skills. Clearly, the therapists do, and the nurses do, and the psychologists. And we also, as medics, have a particular set of skills which we can deploy to the best advantage of the team dynamic, and also for the patient.
Yeah, and I mean, we see clients, Edmund, that have huge multidisciplinary teams, and you have quite a number of clinicians dealing with all sorts of issues arising from neurological conditions. And I suppose what you're saying is that the consultant in rehab medicine is kind of the overarching eyes on everything to see whether things are slipping through the net, anything's missing or could be added. And does that, in your experience, I mean, presumably that goes to the kind of the efficacy of the treatment being delivered by those different clinicians. It's about the pathology, isn't it? And maximizing somebody's medical condition to... It's
absolutely about optimizing their medical condition. It's also about being a kind of consultant to consultant link with other disciplines, clinical disciplines, the orthopedic surgeons, the neurosurgeons, neurologists in the instance somebody's got uncontrollable epilepsy. Oftentimes you want to involve the gastroenterologist, and for all of the reasons of various historical prejudices in medicine, doctors like to talk to doctors. There's just a natural common language, there's a common understanding, a mutual respect, and it's just easier, I think, for MDTs to access those specialists and indeed general practitioners and mobilize their contribution for a patient. If you've got a doctor of your own within the team, and it's not intended that that role of the rehab physician is in any way dominant or domineering. I think that the role of the case manager in terms of coordinating the team is probably the most important. But I do think that MDTs that lack medical input have a serious deficiency in them, and potentially expose patients to risks of complications and not optimizing their condition, which are sometimes dangerous, but oftentimes damaging to their journey towards optimum function, which of course is what we're all trying to get to.
So do you think that there's a case to say that every injured person, I'm talking about the context of litigation because that's the kind of world I live in, but do you think that almost, would you say every case or almost every case where someone has sustained a neurological injury, we should have some kind of input or overview from a consultant?
I'm always reluctant to say every, because it sounds as though one's being completely self-serving and saying, well, we've got to be at the table on everything. And, there will undoubtedly be cases where perhaps an initial input will be enough. I think it's remiss of, in complex neurological injury, cord, brain injury, even peripheral nerve injury, brachial plexus and so forth, I think it's remiss not to at least have a view from a consultant in neurological rehabilitation at the outset, or as soon as that can be mobilized. It may transpire that the case then operates really without complications, really fluently, and that input can be stepped right back, or can be maybe an annual review just in in a telephone conversation or a video conference. But I do think that I find it hard to think of the complexity of cases I'm involved in functioning as well as they should without some kind of specialist neuro rehab involvement.
Where it would benefit. I understand that entirely. And I think it's really interesting to reflect upon kind of the practicalities of it, because that's something that I've asked myself as well about kind of once you have a consultant in rehab medicine on board, does that mean attendance at every MDT? And should that, I'm thinking about, again, lawyer head on about cost effectiveness and kind of feeding into the MDT. And another thing that I've, that's come to mind that I wanted to touch upon, was the availability of consultants, because we know that there are, there are not huge amounts of consultants.
180 in the country. 180, as compared to about 1,000 neurologists, as compared actually to about 50 neuropsychiatrists, who are even more, rarest entity. So it's a small number of people. All of those 180 are not full time. And therefore, access to consultative rehab medicine or neurological rehab medicine as a subdiscipline is tricky. And I think, therefore, that expertise should be used sparingly. And it should make, that's why I'm not saying, we've got to be at every conference, we've got to be all over the case all the time, because actually it's just not practical. But what is practical, I think, is to have a nominated rehab physician for each case, who can be referred to as and when, and who can help the team and the case manager particularly to judge how often that input should be.
Absolutely. And I wanted to plug a webinar that you did a while ago, and not for your benefit, but for everyone's watching, because I watched it and I just thought it was brilliant. You did a panel discussion, which was much longer than 15 minutes and much more kind of detailed. But I would encourage people to watch that anybody that works with people impacted by neurological conditions to have a listen. There's something for everyone in there. You've got perspectives from case managers, lawyers, clinicians. It's really, really good, and we'll post the link to it. So I was going to say people can ask questions, but do you know what? It's 1:15, and we do have one question which I think that we probably answered, which is, do you find many rehab consultants work privately?
Not that many. I think, well, there are about 180 in the country. My reading of matters is that about a third work privately to some extent. And I am working with NRC medical experts to try and increase the availability of people who, rehab physicians who will work privately, included in which is medical legal work, so medical legal or clinical practice. It's a rare discipline, and there are ways to make the delivery of it more efficient and more effective, which again we're working on, so that we can get more out of a very limited resource to the benefit of the teams and the patients.
Yeah, absolutely. And not a question, but a nice comment in from Joanne, which says, as a case manager and neurophysio, I've been fortunate enough to work very closely with rehab consultants, and it's wonderful to hear this. Thank you. Sadly, there just aren't enough around.
Nice, thank you.
That's it. Well, we're 15 minutes is gone. Every week it just flies by. So thank you ever so much, Edmund. And we did say before we joined, unhelpfully, not when you were all here, but if you do have questions, you want to know any more about NRC, any more about anything that we've talked about today, please do send me an email and I'll compile everything and send it to Edmund, because I know that he hasn't got enough to do. And so any questions at all, please do get in touch. And thank you all ever so much for joining, and thank you as well, Edmund, for being with us. Really brilliant to see you.
Thank you, Emma. Thank you, Stuart. Okay. It's been a pleasure. Bye-bye now.
Take care, everyone. Bye-bye.